Hi, everyone. I'm Alexandria. I work at the Center for Global Women's Health Technologies at Duke University, and we're going to go ahead and get started. And we're also going to be recording this Zoom. And so if you have any friends or colleagues that are not able to join us right now, we'll send out the link to the recording and feel free to pass that along to anybody who you think might be interested. So as Ashley stated a couple minutes ago, feel free to keep your video on or off during this call, whatever is most comfortable for you. We will be keeping everyone on mute until the Q&A portion, but feel free to communicate and send any questions over in the chat. Myself and Ashley will be monitoring that, and we'll try to be sure that everyone's questions can be addressed later on. So we are joined today by a special guest who is going to be talking to us about his experience and kind of how that ties into our center's series for this year. Our series is on global health leaders, and we have the wonderful opportunity during the series to learn from some different leaders within our own community here at Duke and outside of our community. So I'm going to turn it over to Nimi now to introduce our speaker.
Thank you, Alexandria. Well, I'm really excited to have my colleague, Mohammed Zaman, here to tell us about his research and his innovation in educational programs. And I just wanted to give a brief introduction to Dr. Zaman's interests. So Dr. Zaman is, or Professor Zaman is, received a number of accolades, and most recently he is a Howard Hughes medical investigator and also a Guggenheim Fellow. And his passion, if I might say so, Mohammed, is to really do work in developing technologies and solutions in global health. And one of the areas that he's made significant contributions to is assessing drug quality as a way of determining ultimately the therapeutic benefit of that drug, whether it be in cancer, maternal health, or fighting infectious diseases. And one of the areas that he's working in presently is looking at poor quality medicines that drive resistance. And some of his work is in with the refugee populations in Syria, and Mohammed, you'll tell us about other places where that's happening. And then I'm really excited to hear about QEPIC that I believe is funded by the Howard Hughes Medical Institute to essentially train engineers to have a deep understanding of the needs in emerging markets, in thinking about solutions for those markets, all the way from understanding the need and being able to create solutions that can actually get to the people who need those solutions, because ultimately it's not just about a technology, but really having transformative impact within the healthcare systems in countries where that's woefully needed. So with that, I'd like to turn it over to Professor Zaman, and we're very excited to hear about your educational program and your research as well.
Great, thank you so much, Nimi, and it's just absolutely wonderful to be part of this conversation. And I hope this will be a conversation. I don't intend it to be a lecture. I will certainly have some slides, but please interrupt me in between, or certainly have any thoughts and comments in addition to questions. I'll share my screen. So it's in many ways it's a journey that still is continuing, a journey of self-reflection in some ways, trying to figure out how do we engage with complex questions of our time, issues of injustice at home and around the world, and the role engineering education, engineering research can play in that, on that journey. This is a picture of a refugee camp not very far from where I grew up in Islamabad in Pakistan. This is an Afghan refugee camp near Peshawar. Unfortunately, the situation may not be very different. This is about 30 years old, this picture. We may be seeing a similar situation. Without even going into the politics of who and what and why, the fact that this place is not appropriate for any person to be in. There is no privacy, there is no dignity. This is beyond what our humanity should allow for any person, regardless of our political differences or anything. And in some ways, I grew up not too far from these places. And I grew up in an environment where perhaps xenophobia and racism was the norm. It was always the outsider who was responsible for all the problems. My community, my folks, my family, my friends, they all sort of normalize otherizing people and sort of finding them as scapegoats for all of our problems. It took me a long time to figure out how problematic that was. I'll keep coming back to some of these issues and how we think about those. Afghanistan is not the only problem when we're looking at the global challenge of displacement and refugees. There are about 82.4 million people who are displaced currently, not just in the last year, but sometimes in the last 70 years. The Palestinian refugees have been displaced since 1948. That is nearly 70 years ago, 73 years ago. About a half of these people are displaced from their homes, even within their own countries, called internally displaced people. And I'll talk about that as well as we go along. With the exception of Germany, all of these, or majority of these people are in low and middle income countries, which means that there are sort of dual challenges of displacement and poverty, dual challenges of displacement and development. Right. So these people are living in Pakistan, in Iran, in Jordan, Sudan, Lebanon, Uganda, Ethiopia, elsewhere. And the German sort of aspect is much more recent in the last 10 years or so with the Syrian refugees, which means that these countries, which are hosting many of these refugees, themselves have challenges of poverty, of lack of equitable access to healthcare. And that makes it much harder for these communities as well. Unfortunately, when we think about refugees, we have a very monochromatic lens. And here, I'm not going to answer these questions, but perhaps these are questions for us to ask ourselves. Who do we think is a refugee? Right? We have a certain image in our mind of what a refugee is or who a refugee is, and oftentimes that is incorrect. We think of numbers in different ways. We think that they're only in 4 countries or 5 countries when they may be on the southern border in this country from Haiti and Central America. We force an identity on them. We call them refugees, whereas they themselves might be calling themselves something else, right? So we use our privilege to identify and define somebody else, something that is pretty awful. We think they all live in camps when that is just absolutely not true. 2/3 of them do not live in camps. They live in urban areas. What is the relationship with the state? We often think that state is the ultimate benefactor, this kind, benevolent community that gives things to the state, where in fact state might be benefiting from their cheap labor. And that those are important questions to think about. And then there are transient realities. People may be refugees and then settle and then become refugees again, right? So there are many of these questions that I ask myself and my students, and we should also ask ourselves as we think about these communities and what our role and responsibility should be, not as modern day neo-colonialists, but as just good, decent human beings. Now, I want to talk today about sort of the questions that are relevant for this conversation, perhaps with a little bit of a quantitative engineering focus. And the first one is, why is STEM absent from this conversation? This has become an issue in political science, in anthropology and sociology, oftentimes not in science, technology, engineering, and mathematics. I'll talk a little bit about reflections of our own work, and then finally talk about building a coalition in thinking about these questions. Just to give you a sense, US has not done well in the recent past. So in 1980, there were about 232,000 refugees in the quota. And for the longest time, US couldn't fulfill that. That number came down to 11,000 in 2020. For the first time in October 2019, US did not take a single refugee. It had never happened in the entire history of the United States. Of course, COVID has made things much harder for these communities as well. In a world where we are much more concerned about me first and my country first, this has only made problems much worse for those who are sort of beyond our blinders of sort of inward-looking world. So let's ask our first question. Why is there limited engagement of STEM? And there are many different reasons, and we've thought a little bit about those. First of all, there's this notion that somehow the problems in these communities have all been solved. It only requires a cheaper version of the existing technology. And if you could get that, we'll be all set. Unfortunately, that is not true. There are important questions in science And there are important questions in technology development, in discovery, that need to be addressed. For example, ethically appropriate point of care technologies. There are design questions there, not just a cheap version, but ethically appropriate that work in those communities. There are issues associated of access and data access and privacy. New discovery needs to be done. For example, when you are displaced, when you're a stateless person, and let's say there's a data breach, where do you go? Whose court is going to be your place to get appropriate solutions for that? And this recently, unfortunately, happened in the Rohingya camps as well. An area that is of interest to us is antimicrobial resistance in these communities. There are important questions driven by conflict, driven by sort of communities that are forced to live in tight spaces, environmental catastrophes and damage, climate change. There are no cheap solution of what happens in Boston or in North Carolina is going to be applicable to these camps. You need to have the discovery part. So this first notion that we have already solved all the problems, and only if you could have a cheaper version of the technology, it would work in a refugee camp, unfortunately, is just not true. And of course, trauma and mental health, which is very complex and an important issue, is something that needs to be understood. The STEM bottleneck also drives from the fact that people would say there are few funding opportunities, and there is some truth to that. But at the same time, you have to recognize that when I was growing up, when I was an undergrad, there were very few funding opportunities in global health as well. And part of it comes from the top, from the leadership creating new opportunities, and part of it comes from the bottom as well, people advocating for new areas as well. So if we want new funding opportunities, we have not only to sort of hope that there will be more support from the top, we also have to rally that support from the bottom and argue that there is a need to do better and improve things there. Traditional approaches in STEM disciplines try to focus on control groups and sort of control experiments, and often are unable to handle the complexity that comes from ethics, that comes from colonialism and racism. And we need to really train our people to be able to deal with that complexity, confront the history and the past of those things so that we are able to make a contribution. We will not be able to use sort of the same kind of approaches we've used in the past, which have sort of marginalized groups of people, or we have sort of really looked at communities and said, oh, this is too complicated, too difficult for us to do, so let's move on. We have to really do that. And of course, in that regard, education is a central piece: perception, awareness, and education of current and future practitioners. There's a huge, and this is a positive thing, there's a demand from the student side. You see a number of students here as well. But we, as educators and instructors and professors, have not sort of understood that, that demand very well and have addressed and develop solutions for that. So one of the most important things, I'm going to move to the research side of this conversation for a little bit. One of the most important things when you're dealing with a community that is vulnerable and marginalized is trust. You cannot sort of just parachute in and sort of say, I have the solution to your problems, take it or leave it. You really have to work slowly. You have to work with people who are from that community. You have to be sort of perfectly fine in being told, we don't want you here. You have to be perfectly fine in not being in the driving seat and be part of that coalition. That trust takes time. And you really have to build it if you really want to make a contribution. One way we have started thinking about it is building that trust by improving the system as a whole. So Nimi talked a little bit about this technology about improving the quality of medicines. That is not about sort of a clinical technology that works on an individual person, but improves the trust system in medical care as a whole. The issue of quality care is universal. COVID has made it much worse. The fake pharmaceuticals, fake diagnostics, and we work in this area. And this is something that we believe is among many things that other people are doing, can make a contribution in improving trust in the system and also help the community at large, not just people who are in the camps, but people who are in the neighborhood as well. Oftentimes there's a distrust that why is the refugee camp getting medicines made in Germany while I get the medicines made in Pakistan? So you want to make sure that nobody feels marginalized. Nobody feels that they are otherized, that they are sort of getting the short end of the stick. Conflict oftentimes destroys health systems. which means that not only you take away the doctors, the clinicians, the public health practitioners, but the infrastructure is also destroyed. That leads to counterfeit and fake and substandard medicines and technologies to sort of fill that vacuum. And that is something that we are very cognizant of and we want to contribute towards. Of course, poor quality medicines come in all forms. They come in bad manufacturing, sort of unauthorized and unlicensed groups making drugs. Supply chains can be affected, and you may have drugs that are expired or have long sort of lived past their efficacy. There is also, of course, at the bottom left, we're seeing intentional falsification, misleading the consumer, and of course, lack of regulatory framework. And I'm not picking on a particular country here, but the lack of regulatory framework often hurts the most vulnerable. If you don't have money, if the system doesn't take care of you, you are going to go to the cheapest provider. Oftentimes, that is not necessarily the one who may have the best possible medicines for you. On a global scale, we are looking at a problem that goes from anywhere from 30 to 50% of, 10 to 30% of drug sales. Most of them happen to be antibiotics or anti-infectives, which leads to this whole issue of antimicrobial resistance, among other things as well, right? So you already have limited access to healthcare. You may have a higher exposure because of the environment that you're in, and then you're getting poor quality medicine. And this reinforces these terrible and awfully racist kinds of sort of notions that, oh, these poor people, they're always sick, and hence everybody else falls sick because of them. Right. So this fact that people are first forced to live in urban slums, and then they also bear the brunt of all the collective guilt that, oh, the problem starts from these poor people. These are pictures from a refugee camp. There was in northern Uganda where we worked. You could get basically any medicines that you wanted, all the way from dental care to antibiotics. And they were available, and there was a high demand for it because the system themselves, the system for these people was failing. So they would go to an unlicensed pharmacy and basically ask the pharmacist, who was also not trained, to tell them what to take. So the goal here is system improvement. The goal here is to be able to say that can we detect poor quality medicines and potentially save vulnerable lives. I won't go into the technical detail. I'm happy to have a conversation on that for colleagues who may be interested. The idea for PharmaCheck came from a number of years ago, and I see some colleagues here who have worked on this, who are students at BU and now are at Duke. The idea is to improve access to good quality medicines at every point, no matter who you are, what you look like, how much you earn, how far you live. You should have access to quality medicines. It's also important for us to not market this as a consumer technology. Somebody who's already paid once should not have to sort of pay again to get their drugs tested. You've walked 6 miles to get medicines for your kid. You should not have to worry about the quality of medicines and have to pay again. The system should take care of you. It's also research to understand where the bottlenecks are, to see whether conflict or rainy season or dry season or distance from a facility changes the quality of medicine, to be able to really get that data, to be able to make policy level decisions. Of course, we're very interested in technology innovation for vulnerable communities, but also hoping that it would feed into policy development as well. So the way it works is that we have worked on developing DNA and RNA aptamers, which are basically fluorescently tagged, that upon binding to the pill would change conformation. That change in conformation can be directly correlated with the amount of the active ingredient, and the active ingredient concentration can be measured. If you do it as a function of time, you're also able to see how that active ingredient is released from the drug, right? So you can get both identity information and the information about dissolution. Of course, this allows us to work with many different brands, but there's also, I think, appropriate criticism. Can we do it for every drug? The answer is in principle, yes. But given the resources and the nature of the problem, we're focusing largely on anti-infectives, anti-malarials, and antibiotics. The idea is to have a simplified user experience. You have sort of these pre-filled cartridges that would go into the system, And then you have an optical sort of a nest that where you have a small pump that would take the aptamer that you have for a TB drug or for an antimalarial, for an anti-infective, that would combine with the drug which has been diluted, and then you have a standard curve against which you measure. We've been very fortunate to work with US Pharmacopoeia, European Pharmacopoeia, as well as national drug authorities that tell us what the actual drug should be, right? So we have basically standards that are built into the system and these cartridges, as well as sort of available within our sort of a database as well. So you can compare what your information looks like. We can basically test nearly all the major antimalarials that are available in the market, whether they are in fixed dose combination or whether they are given as separate pills. We can also sort of work with different brands. We've been working with some of these companies as well in improving the quality of their drugs, as well as sort of working with regulatory authorities in a number of countries in West Africa and Ghana, in East Africa and Kenya, Indonesia, Philippines, and more recently in Pakistan. Just to give you a sense of the technology is not a replacement for HPLC. It is more a frontline technology that allows you to be able to do something that currently is done in a very qualitative way using thin layer chromatography. We can certainly do better than that, and we can do sort of much more quantitative analysis of this, which is well within the 3 to 5% of HPLC. We haven't marketed this yet. We are very, very close to that within the next year or so, but it would be about 100 times cheaper than HPLC. So in the $1,000 range, as opposed to HPLC, which is about $100,000 range. The idea is to empower local communities. So this is our friend Alfred, and I sort of got his permission to use his picture, who works with us in Ghana. And the idea is that you're able to sort of empower the local communities and the local regulators to be able to test things rather than having no testing facility at all, and get tests that are more relevant for that particular market. Currently, there are oftentimes no points of implementation. The reason it matters is that because there is no implementation, people who are vulnerable, refugee communities, people who are marginalized because of their gender or because of their sexual orientation or because of their religion, oftentimes fall through the cracks. By strengthening the system, we hope, closer to the camps as well, we hope that we'll be able to get both the data and empower the system to improve the quality of medicines. So the idea is that we want to sort of place these at multiple points in the supply chain. In the last, I would say 7 minutes or so, I want to sort of take a different aspect of our work and talk about it. And that is, how do we create local and global engagement in understanding important issues of our time, and using technologies such as PharmaCheck and bringing change at the ground level. So the idea is threefold. We want to create exposure, we want to create experience, and we want to create engagement. By exposure, we want to bring new sort of content to our classrooms, sort of difficult, complex challenges of our time, refugee health, people who are forced out of their homes because of conflict and climate change, and talk about their health in our classrooms, in our engineering classrooms, whether it is in design, senior design, or sophomore level design, biotransport, other things, and talk about sort of the challenges so that students do get an exposure to the fact that our problems don't emerge just from textbooks, but emerge from the complex issues of our time: urban poverty and lack of access to care, antibiotic resistance in these environments. We have a component, and I'll talk about that in a second, that takes students to the field and community, and how do we do that ethically is an important issue. But we also want to make sure that these questions are discussed in the classroom as well, and talk about sort of the challenges firsthand. And finally, it would be, I think, naive and absurd to think about these issues only from the lens of engineering. These are complex issues that require engagement beyond engineering. We have to understand historical aspects, injustice, economic issues, the political realities. And we do that through classes which engage philosophers and ethicists and sociologists as well. Just to give you a few examples, we have had students who have worked in Zanzibar in sort of maternity wards about access to medicines. We have worked in supply chains with our students. We've looked at the issues of data in these wards, in these supply chains, and have thought about sort of how to work with the local policymakers. It's very, very important for us to really work with local partners and not necessarily try to impose the world as we see it sitting in Boston and sort of impose that on others. The key component of our program is immersive learning, and we have 2 versions or 3 versions of that. And the winter course has been in Lebanon, where there are a significant number of Syrian refugees. And we work with American University of Beirut and their students and their faculty. The summer version is in Uganda and in Colombia. There are several aspects of these programs that we are very proud about. First, they're inherently interdisciplinary. Engineering is a small part of that. 2, there's a strong component of working peer-to-peer. Our students work with their peers, other students, to be able to understand from them and their partners. 3rd, we are by no means drivers of this. We sort of are learners and students in many ways and help and are helped by our peers in these universities. And 3rd, the way the courses are designed, they are taught by experts. So when we're talking about Syrian refugees, there's a historian at the American University of Beirut who talks about Syria, who talks about the demographics, who talks about these, so that our students learn that. It wouldn't be me, and it wouldn't be appropriate for me to talk about that because I don't have expertise in that. Same thing in sort of nutrition. A nutritionist or a scholar in nutrition would do that. And the same is true in other programs as well. The key goals of the, in January 2022, because of travel challenges, and also because we don't want to impose ourselves on other countries and other communities which may already be struggling with COVID and post-COVID sort of rebuilding, and also because we should look at our own border. The problem is not just way out there, the problem is very much here as well. The problem of injustice and racial discrimination. So we are working with sort of communities and universities and partners who are looking at the challenges faced by migrants from Haiti and Central America. And we'll have a very similar program this January in Texas, in Brownsville. And we're working again with universities, with public health groups, as well as with groups that support and help our Haitian brothers and brothers and sisters from Central America get equitable access to healthcare. And sort of really understand those challenges in a way that both decolonizes the curriculum, but also gives us a better understanding of the injustice and what role engineering and science can play in that. So what are some of the key goals of these courses? They are combined with sort of teaching through the semester, but during the courses, one is learning from experts, right? We want somebody who deals with public health of people who have applied for asylum, public health of colleagues who may not have the certain documents, and trying to understand where the barriers are. But are the barriers in access? Are the barriers in information? Are the barriers in trust? And how do you sort of build that? Peer-to-peer learning is a central part of that. I think we recognize that our students today are much more plugged into many of these challenges than I was when I was their age. It's important for them to learn from other peers of their own generation and try to sort of grapple with some of those issues as well. And of course, how do we make sure ethics is a central part of this experience, that we are not voluntourists, that we are not sort of coming in for some kind of a self-satisfying experience where we just feel good about ourselves and there's no value to the whole experience for the communities. In some cases, the answers are quite uncomfortable, but it's important to have those discussions as well, and that's important for building trust. In certain cases, and this is a positive example, we've had support from policymakers. So this is the former Prime Minister of Uganda, who was the Prime Minister at that time. We got a chance to work with him and his office as well in thinking about what we can do, the areas that we identify, and building sort of long-term partnerships as well there as well. So I'm cognizant of the time. It's 12:30. I think it's far more interesting for me to hear from you rather than to hear myself talk. So I want to end. This is a picture I took myself from in northern Uganda. And if you look at the picture, there's a barbed wire. There's a tremendous sense of exclusion. And this was a health camp. for providing health. It does not look like one. The environment here really is more about keeping people out rather than bringing people in. And I thought about it, and I was very unhappy with the whole image. And so I came back and I was thinking about it, and I sort of read a little bit more. And it was a little bit, I think depressing to realize that we have been on the sidelines for way too long, we as in colleagues in engineering and sciences. And I was reminded of a quote by another Boston University professor who sort of argued for human rights. His name was Elie Wiesel. And he said that the opposite of love is not hate, it is indifference. So for far too long, we have been indifferent. We have been indifferent to the challenges faced by other people, just like me and you and our kids and our family members. And we have been indifferent because we have lived in a very privileged environment in engineering and sciences where we can control our experiments. And I felt that I personally and professionally wanted to change that. So I want to end with this, that the opposite of love is not hate, it is indifference. All right. Thank you very much, everyone. So I'm looking forward to the conversation, as I told Nimi and the organizers, that I'm happy to come back and for a longer conversation at any point. But yeah, let's hear what you have to say. So I'll stop sharing here.
I just wanted to start by saying thank you so much, Professor Zaman. It's wonderful to see health equity and equity be the undercurrent of your talk, something that we really need to engage our students in. It really matters for future generations. So I actually have questions that came before the talk. I have a few questions, and then, maybe as questions come in, we can open it up to others. So the first question, as a current medical student and a future physician, what can I do to help refugee healthcare?
I don't know if I'm the right person to answer, because you are at an institution that has such rich history and expertise in dealing with complex issues. You may have refugees in the midst of the Durham area that you may not know. Look around, right? I did not know that there was such a huge refugee population in Boston, and BMC, the Boston Medical Center, is a minority serving sort of a public hospital. So I would start with that. There are also tremendous opportunities globally for people like you to really think about what you can do. So some of them are often uncomfortable, taking a year off, taking a semester off, and people are unwilling to do that for a variety of reasons, and I fully understand. But then there are other opportunities as well within your own hospitals. But if you choose to really, and if you have the ability to take time off, the most important thing you can do is to really experience the challenges, not as a voluntourist, but sort of rolling up your sleeves and trying to understand where the problems are. I think books do a great job and videos do a great job, but there's nothing at all that tells you and trains you when you've spent some time there and confront your own privilege and recognize the inequity in the world that exists and things that we take for granted. So I would encourage you to sort of be a part of these programs. And there are many programs that are ethically grounded that allow you to sort of understand the challenge without sort of putting anybody under the microscope, right? Mm-hmm. So I'm happy to sort of share that, but there are a number of programs and number of conferences that really sort of look at refugee health. But I would also start from your own backyard, whether you're in North Carolina or elsewhere. There are people, often invisible to us, who really can benefit from your knowledge and your compassion.
Thank you. In fact, there are so many questions related to just that issue of how can we get involved. Another question is, how has COVID and disruption of supply chains and health services affected refugees' access to quality health services? Where are the major gaps that need to be supported?
So that's a really good question. Unfortunately, the most prominent and the biggest gap actually is in our own values. It's not in supply chain. It's about sort of saying me first and my family and my kids and my country first. And I fully understand the love and the affinity we may have for our family, but there is a problem when certain kinds of profit, certain kinds of worldviews mean that people may be getting a booster shot in one country and no vaccines available in another. And that is not just true globally, that is true internally in countries as well. So in Pakistan, the country where I'm from, the stateless communities, this Bengali stateless community was actually not even eligible for vaccines. So it's not, I mean, it's not even a question of whether they don't have vaccine. They were not even eligible because they didn't have the passport. They didn't have the citizenship, right? So this really becomes a problem in many ways. And that's a problem that has little to do with supply chain and more to do with our ethics and our sort of values. So that's the first thing. Let's confront our own values and our own sort of ethics. And this is not just a problem in Pakistan. We've seen this flu vaccine denied to people at the southern border multiple times. And the irony of the whole thing is that there's not even a policy. So it went to Congress. I've sort of been working and reading on this, and there was no decision. It was basically on the whim and the impulse of the people at the border. So if they chose, well, you get it. If they choose not to, so you don't get it. So I think the first and the most important thing is that perhaps it's a time for us to look at ourselves in the mirror and see who we are as people, and whether when we champion equity, is it an empty slogan, or do we really sort of walk the talk here? So that's the first thing. On a more broader issue, the challenge of COVID, as somebody wrote, Danny Roderick at Harvard, has only accelerated the gaps that already existed, right? So people who had limited access to healthcare are now facing an even bigger access to healthcare. So those are already sort of those fissures, those gaps are already there, and you're seeing a bigger issue as well. So, for example, when there's a complete shutdown in a city where there are refugees, what that means is that they cannot access basic services, right? So they cannot go to the hospital. They may not have transportation. There's also sort of a lot of xenophobia, which means that there are now fewer places for them to work and even fewer places for them to get access to nutrition, to medical care. So we are seeing some of that as well. The third one is, of course, stigma, that if you have COVID and if you're a poor person, there's a huge stigma. So people won't get tested because I mean, just imagine how we think about somebody who has COVID. Maybe empathy, maybe negative thoughts about those people. But if they're already sort of vulnerable, then that makes it harder, because people will say, oh, look at these poor people, they have COVID and they're sort of bringing this awful disease to us in our nice neighborhood. So some of these things really compound and make it harder. And final point is, of course, we have done a pretty bad job in collecting data. So we don't really fully understand how COVID has manifested itself in some of these communities. And what are people's fears, mental health, trauma, all of those things as well.
I was on mute, not figuring out how to quickly unmute. So another question is, PharmaCheck, you said that it'll be in the market soon. How do you get that to the health systems that need it at an affordable way, given that there has to be a balance between sustainability and being able to get this technology to the communities that need them, that may not have the resources to pay for it?
So that's a really good question. I think the most important issue we have to think about right now is who is our customer, and our customer is not a person in some ways, even though our hope is that the impact would be on individuals. The customer is actually government. The customer is a large network of public health hospitals. And what we want to do is we want to work with them in ways that allows them to be able to pay for this and sort of to integrate within the system. So that makes it actually harder, because that would mean different business models in different communities and different countries. It also may mean that our customer actually is not the government of Ghana, but it's actually Gates Foundation. So we have to sort of convince Gates to be able to buy a lot of these. So that's how we are sort of thinking about it. The other part of this is that for-profit companies, Merck and Novartis and GSK, are actually very interested in strengthening the supply chain in countries. So the goal would be, in that case, to really work with them and use their resources to subsidize it 4 countries as well.
So I'm sort of aggregating the questions that I have by topic. So I just wanted to let you know so that when the audience listens, they sort of have a theme. Another question is, what can be done if the drug is of poor quality? What actions can be taken given a result?
So that's a really good question. And we have to be very careful in not replacing or substituting law enforcement. We don't have any legal or ethical right to do that. And I don't think we would be the right group to do that. Our goal is to provide data as transparently as possible to the appropriate authorities. And before we sort of, let's say, get into a partnership with a country X or a government Y, we would hope that we will find ourselves in alignment with the values. And I think that is going to evolve. And I think if we feel that the government is really not doing much and we are constantly getting reports of poor quality medicines and nothing is changing, then I think we'll reevaluate. But we have to go with 2 ideas. First of all, ultimate change is going to come from within, not from outside. So we really have to do that. 2, you have to go with an optimistic attitude that there are good people in every system who care deeply. So I may care about people in the world, but there are people from that community who care a lot more. And we have to recognize that and not say that I somehow am sort of this messiah and everybody else there is corrupt and doesn't care much about it. That is just extremely problematic. So you hope that you will get to work with people who share your values, and that sort of happens before you really sign any contract or long-term partnership. But ultimately, we don't want to be a police in any country, and we don't have any right to do that. What we do want to do is to provide data as transparently as possible and hopefully work with groups that care about data and transparency and sort of mobilizing the civil society for better care. What we want to do is ultimately make it unimaginable that people will get poor quality medicines, that you would go to your corner, whatever hospital or your version of Walgreens that exists there in whatever form, and what you get, you don't have to worry about the fact that this may have been counterfeit. I don't think anybody here goes to Walgreens and gets their prescription and has to worry about that. We want to reach that level of trust, right? Because that, in my mind, is a basic right of any patient, of any consumer.
Related to that, there's another question of, so are the people who make these poor quality drugs, do you know the source and how they can be held accountable?
That's a really good question. Oftentimes, we may not know the source because in most low-income countries, drugs are made outside the country, right? So the powerhouses of manufacturing are India, China, Brazil, certainly Western Europe, United States as well. So in some cases, you may not know whether it was the problem at the origin or whether there has been sort of tampering through the supply chain. It's hard because the supply chains are often quite complicated. 2, what your question implies is criminal intent, which is true in some cases, but not always the case. For example, there may be instances where somebody has made poor quality medicines because they're not following the rules, not because that they are intentionally falsifying it, right? So because there is no regulatory framework that enforces these 5 steps and quality control, that the company itself doesn't abide by good quality control, and hence it leads to the production of poor quality. That is certainly problematic, and I have absolutely no, I would never want to defend it, but that is a different situation than intentional falsification and misleading the consumer. Go ahead.
I have a follow-up question related to that, which is, do you envision a case where you may not know the source, but you have a way maybe to democratize that quality control step, say at a local hub? So let's say you have the equivalent of a CVS in a community. That instead of knowing the source, you're sort of dealing with the consequence, and there can be some sort of way to say, we can't accept these drugs, or, we need a new supply, so that some action can be taken at the community end to sort of deal with that lack of knowledge of where it's coming from, regardless of whether it's intentional or just something that that isn't in place for the quality control to even happen.
Absolutely. And this is brilliant. I mean, to be honest, we've been thinking about this, and you really nailed it, because the idea is to democratize it and empower multiple sort of units on the point. So first unit is that the customs at, I don't know, I'm just making it up, in Nairobi or in Mombasa or in Accra or in Karachi says, look, we're going to test these before we accept. We don't care who made an error, but we're not going to take it. And you build it in the contract eventually, saying that we will test some kind of a statistical sample or even a non-statistical sample before we have any payments, right? And if it is not addressed, then we will either return it, and then we have a legal right to get our money back or something like that. And then that happens all the way in the supply chain, that ultimately the CVS in your community, ultimately the hospital in your community is also able to say, well, we want to test it, and we're not going to pass it down the supply chain until we are satisfied with it, right? So in other words, you create a culture of quality and then disincentivize anybody who's not following quality control for doing that. The other side of this is to use PharmaCheck within the company and test quality control within that, and sort of address any issues that may be coming from poor quality. So one of our partners company is trying to sort of do that as part of the QC system within company, to be able to do that.
So I have more questions that were sent to me, but I was just curious. I just wanted to let the audience know that I'm not monopolizing, and if you have any follow-up questions or discussion items, please feel free to jump in. No need to be polite. Another question is, how can I get involved in so you got a question before, and how can I help? But this is, how can I get involved in education related to refugee health as, again, a medical student?
Yeah, so I would say there are several. I mean, so again, this may be shameless self-promotion, but we've had students from outside BU who've been a part of that. What we ask for is that you are genuinely committed. You'll spend some time with us, 2, 3, 4 weeks, be a part of that process, and you feel that this experience is valuable to you in your personal and professional development. I've had students from other countries. I've had students from Norway. I've had students from other institutions as well, and we are happy to work with that if time and space permits. I think the educational part, perhaps the most important component of that, is to go outside of your discipline and environment. Talk to people who are studying migration in anthropology and sociology. Duke University Press has significant presence in this area and publishes some really outstanding books on issues of migration, on displacement. So I think we have to sort of let go of our disciplinary baggage and really sort of roll up our sleeves and say, I want to understand the drivers of why does somebody chooses to leave their home? What are the factors that drive them out of their home? Is it conflict? Is it climate? Is it collapsing economy? Is it persecution? And try to understand that, and then sort of bring it back to your own discipline and see how you can contribute. Because unless and until you really understand the problem, and I'm no expert in that, and I have a long way to go, but for me, it has been very insightful to spend time with colleagues outside of my department to be able to understand the drivers and the socioeconomic, environmental, political factors, so that I am more useful through my training to be able to contribute in whatever little way I can. So I would strongly encourage you to go outside of medicine and sort of spend time with people who really do that. Anthropologists, sociologists, international relations colleagues, people who are working on human rights, lawyers, and that will really open up your perspective and give you more knowledge and more, I would say, ability to contribute in a meaningful way.
So I have a follow-up to that particular question, which is, it's great that students get exposure, but not everyone is the same. And how do you teach, or how do you engage students with that empathetic process, that we're not the ones who know everything. I mean, I lived in a country that was colonized, and I think about this sort of trickle down of solutions, and you've emphasized that that is not the way to go. You need to look at assets across the board, and hence the near peer education. But how does one develop that empathetic? I mean, I don't know that we teach that in engineering per se, but how do you cultivate empathy so that people recognize it's not just about who knows what, but it's making a commitment to understanding the people, the cultural differences, the social norms, etc., to work with humility?
Yeah, so that's a hard question in the sense that I think it takes a long time to do that. But one of the ways in which we have done is we have introduced a sophomore level course that is taken by, so this is in the honors college where I teach, along with the person whose expertise in gender studies and a political scientist. And the focus is global displacement. So I talk a little bit about health, the limit of engineering technologies, the ethical issues associated with that, and somebody talks about other things as well. So I think the burden for that, Nimi, is on me and you to create opportunities for students, right? So the burden is not on the students to do that. The burden is actually on us to really, and especially the fact that we are privileged to have tenure and do not have to worry about somebody sort of evaluating our work, is to take that chance and talk to a social scientist or a humanist or a public health person and say, look, there is a gap. We are not teaching our students empathy, and we need to offer this course. And we need to offer it perhaps even when it goes beyond our teaching requirement from the department, that we do it because this is the right thing to do, even if it is not as compensated as it ought to be, right? So we really have to do that, me and you and others, and create that opportunity for our students. And the students have to do that same thing as well, is to go outside. Instead of taking one more elective, maybe take one that really pushes you in sort of your humanities and social science requirements, that allows you to really read something that is different, that allows you to read uncomfortable stuff, that questions your own preconceived notions. So I think it's about recognizing our own inadequacy and trying to sort of build that, but build that through a coalition, through a partnership with others who may know a little bit more or may think differently. So I think it has to be very deliberate. Unfortunately, it doesn't happen organically because there's a disincentive for that to happen organically, right? People in science and engineering have absolutely no incentive to offer a new course on health of vulnerable communities. It is much easier to take the well-trodden path and do the things and do it well. And I think there's tremendously valuable. But that the problem is it reinforces the same problems. It creates a certain kind of privilege. It takes away from the opportunity to learn. So that has to be deliberate because it doesn't happen organically. It doesn't happen in my department. There's nobody in my department who does that because there's no incentive to do that.
Yeah.
And the colleagues in my department are absolutely brilliant, far smarter than I am. But there's very little incentive to do that. And they do other things as well, which they do really, really well. So we choose our areas.
So I'm going to ask one more question from what I have, and then I'm going to follow up that with to be sensitive to your time. I think I would love to hear sort of your thoughts overall in this space and in closing. So the question that I have is, you have stories that you have shared. There's the hard data, but you also have the stories. So what role do you think storytelling can play in this process, in this dissemination of knowledge, engagement, experience that you refer to?
Absolutely. The role of storytelling, the role of creative nonfiction, the role of engaging community is absolutely essential. Just look around. What makes a bigger impact on you? The statistics for COVID or a family member who has gone through COVID, right? That struggle makes such a big difference, even though that is one person out of the 78,000 who tested positive yesterday, right? So that sense of connection is absolutely critical. Data is very useful to back it up so that somebody says, well, is your family member, a colleague, a friend an exception. You say, no, there are other people as well. But at the same time, that experience, we all love to read stories, whether they are in the church, whether they are as kid stories, whether they are in the newspaper, whether that's on your Netflix show. That engagement of our mind happens through stories. So that is absolutely critical. I cannot emphasize this enough. I wish all of our engineering and science departments would offer a course in creative writing. Even if you're not going to be a creative writer, learn how to sort of be able to explain yourself, your data, in a way that is meaningful, that can relate to your neighbor and your grandmother and your kid's middle school teacher. That's absolutely essential. It also sort of disarms people. We live in a very polarized world of red and blue, Republican or Democrat, this or that. The ability to have stories allows us to have that human connection and takes away from that sort of otherizing everybody, that there's a common bond of humanity where I can tell a story and I can hear one as well. And I feel very strongly about it.
So for every time you answer a question, I have 5 more, and I always have to be disciplined not to take away from the questions that I have.
I'm such a terrible, I mean, this tells you that I cannot be precise or concise.
No, it's just,
no, you're absolutely right.
So I'm going to take over. I'm just going to follow up on that question too, which is something I struggle with. And oftentimes when you read about an issue, like cervical cancer, for example, WHO says that's a best buy, and then here's the guidelines. And people do what it takes to solve that problem. But ultimately, I feel like the purse strings and the decisions are in the hands of people that don't necessarily, understand or appreciate, what happens, say, in the life of a woman on a given day, or, her life history, something we've been talking about in class. How do you connect? You talked about stories as a way of really disarming people, but how can that work in the policy sense? Because I feel like there's a big chasm between those lived experiences and the fact that someone may not be able to access high quality medicines because of their, understanding of what medicines do, or the lack of a policymaker to understand what they know and what they don't know, and the emotional connection that elicits change that can be so sustainable.
That's a really good question. One of the things that I've learned in my engagement, limited engagement with policymakers in Pakistan and Uganda, is what really matters at the end is actually not data. It's a personal relationship. It's being able to convince someone that this is important and why should they care, right? So I can give data on pretty much anything, which is a problem in Pakistan and Uganda, but only one of those 15 things, which are all urgent, will get funding. And oftentimes the one that gets funding is the one for which you have a personal relationship and you can convince that this matters. It's not to say that the other 14 are not important, and I wish we lived in a world where all of them would get funding, but that doesn't happen. Politicians and policymakers make choices based on their own set of criteria, their own priorities. Sometimes those priorities are ill-founded and awful, and sometimes they're driven by a lived experience. So I think the value of that, of storytelling, of that engagement that goes beyond the data, because you have to have good data to stand up on that, but that's the first step of that. The proverbial sort of signing of the check or the opening of the purse strings happens through that personal connection, which I think is something we in science and engineering are not trained to do. We live in sort of the fact that where we say a curve going up, that should be sufficient. Unfortunately, it's not. Having a face to it is in some ways far more valuable than that. Doesn't mean that one should sort of create stories which only sort of tug at your heartstrings and don't have substance to it, right? We don't want to create something that emotionally drenches you, but not sort of back it up with data. But being able to sort of tell the lived experience, I think, is just really, really important.
Thank you. Before I ask for your closing statement, I just want to tell everyone that I just got this book from Mohammed, and I'm so excited to read it. He's a gifted writer, and I read I've started, and I just wanted to say that I highly recommend reading his creative writing and about his inspiring work, thinking about the long-term effects of not getting the care or the medicines that will help therapeutic outcome, but could actually be a disservice in terms of developing resistance and actually making things far worse. So Mohammed, as a closing statement, I just wanted to get a sense of what does this all mean? Where do you see us going? What are your sort of thoughts after this discussion?
I think, well, the only thought I had is that I would love to come again and as frequently as I can. So that's the most important takeaway, that we've just started the conversation. I think broadly speaking, what I would tell students, and I know there are many here, is that this is something that I came to much later in my life, and I'm so glad that you're doing it earlier in your lives. And I think it's just such a, despite the awfulness of what happens to refugees, there's a human side to them as well. I remember very clearly when I first went to a camp at the border of Syria and Lebanon, and my Arabic is not very good, but there was this woman who actually wanted to talk to me about her tomato patch, right? So she loved gardening, and my wife loves gardening. The human connection is so much more powerful than thinking of them as people who are dependent on you. And that is why I am in this, because I get to meet these remarkable people who are just having a difficult time because of our own inadequacies, our own racism, our own colonialism. And we can sort of really develop that relationship. And these people are just beautiful inside and out. So if you just get the chance to be a part of the journey, your own journey, you'll find, I mean, I am a better person today than I was 5 years ago, not because of anything I did, but because of everybody else who benefited me rather than the other way around. I don't know if I did anything for them. So that journey of discovery, that journey of finding who we are as people is just such a rich journey. And I hope that you'll continue on this. It's not easy. There are plenty of disincentives for that, but I think it's totally worth it.
Thank you so much. And I really appreciate your time to talk to our audience. And I appreciate all the questions that I got. It makes it a lot easier to sort of organize and be efficient. So thank you for that. And Mohammed, I look forward to reading this and learning more about your work, and just amazing talk. Thank you so much for your time. And I look forward to organizing more discussion. You've already given me like lots of ideas, and I've taken copious notes. So thank you for that education as well.
Well, the pleasure is all mine. I'm so glad that you thought that I was worthy of coming to this conversation, and I hope that we'll get a chance to continue this conversation in person and Zoom and email or any other way.
Thank you, Mohammed. Thank you so much.
All right. Take care.
Okay, bye.
Bye.
And if everyone can hold on, we have an announcement to make.
Yeah, so first of all, thank you if you're still here for sticking with us. It's been lovely to have all of you. I just wanted to give a shout out. Next month, we're going to be doing our next Global Seminar Health Leader event. You can RSVP using the link that's in the chat, and you'll receive a follow-up email as well to thank you for coming. Provide us some feedback on this event, what you would like to see in the future, and of course, the RSVP link for next month. So just keep an eye out for that, and thank you so much.
Thanks, Ashley. Bye, everyone. Thanks for joining.
Bye.